Welcome everyone. Let me introduce my PhD thesis called Hungarian Hospital Clinical Pharmacist Position in the Healthcare System. I started working as a hospital clinical pharmacy resident at Semmelweis University, and in the beginning I find a very hard way to find a way into the ward, because in Hungary there is no uniform way to do clinical pharmacy services. And along the years I found out there are several island-like projects in Hungary, but there is no common way to do clinical pharmacy services. And my vision is every hospital needs a pharmacist in the clinical ward, and I would like to support this idea, this vision, with my PhD thesis to provide evidence for our services. I have 3 ongoing projects regarding this issue, and I would like to begin with a pilot study that started in 2017 to try to find a way to document our pharmacy services. In Hungary there is approximately 500 hospital clinical pharmacists, and because of a new residency program started from 2010, there is a high influx every year from new hospital clinical pharmacy residents. But as I said, there is no official documentation system, and there is no official guideline how to properly do our clinical pharmacy services. And the aim of this investigation was to try to find a way to firstly try to document our pharmacy services in the ward. And for this I found a guideline from Pharmaceutical Care Network Europe, a classification system for drug-related problem, and I formed an online questionnaire regarding drug-related problems and non-drug-related problems. And throughout these 4 years, 12 pharmacists participated in 9 clinics, and there were over 900 clinical interventions regarding the drug-related problems, with the acceptance rate from physician over mostly 90%, and there were over 600 interventions regarding other types of services that we can do. The top interventions we did is basically we try to consult with the physician. Firstly, we proposed, discussed, and informed the prescribers about our insights, what are the drug-related problems. And the top interventions we made, basically it was the therapy modifications of drugs, dosage changes, drug stoppages, and drug startings. The other issues were patient education, literature reviews, professional and patient consultations. And to conclude this pilot study, pharmacist insight could help to improve patient healthcare outcomes, because if our colleagues weren't there in the ward, these problems will stay in the system and maybe harm the patients in the future. And for the second project, I would like to broaden this idea, this documentation system of the pharmacy services. We had learned some lessons from this pilot study, and I would like to qualitatively and quantitatively assess pharmacy services, and not just in Hungary, but in an international registry, because in Middle Eastern Europe, pharmacists suffer the same. They are not as well regarded as they should be, and the aim of this bigger registry initiation to establish evidence-based pharmacy services for reimbursement for healthcare decision makers. It's in the early phase. It's basically, we started the literature review, how to conduct forward with this project. And with a pharmacist in the multidisciplinary team, there is a new insight to help patients to improve their health outcomes, because pharmacists have other way of thinking that can add to the patient better outcomes. And this led to me my investigation that it's consisting the ulinastatin combination compared to somatostatin analogues in the treatment for acute pancreatitis. Acute pancreatitis is the sudden inflammation of the pancreas. Its incidence rate ranges from 5 to 100 cases per 100,000 inhabitants. Its mortality, highly depending on the severity of the form, it can achieve 40%. However, there is no efficient pharmacon yet. Only supportive therapy is warranted for this patient. And our aim to investigate the clinical outcome with this ulinastatin combination. And I would like to add, because in Asia, this ulinastatin combination is very common. However, in the Western countries, there isn't much evidence for the usage of this ulinastatin combination. And I would like to investigate, is this therapy is justified for the treatment acute pancreatitis patients? The clinical question is, does this combination have a superior efficacy to the standard therapy, that is the somatostatin analog alone? And our hypothesis is that it is a superior treatment for compared to the somatostatin analog alone, and it could be a huge step for treating patients. We conducted our literature research in 4 databases, and after the selection process, we identified 8 eligible articles, and we've got the first preliminary result from our statisticians regarding the length of hospital stay. As you can see, there is the meta-analysis found that this favors the ulinastatin combination and is statistically significant improvement. The second one is the abdominal pain reliefs. It also favors ulinastatin combination. It is also significantly higher impact. Mortality rate, unfortunately, it's not statistically significant. However, it also favors ulinastatin therapy. Our strength for this meta-analysis is the search methodology and transparency that we provide. The limitation are the small number of trials, the high heterogeneity, and the different therapies and follow-up days that they reported in the articles. The clinical implication will be maybe a new medication therapy for acute pancreatitis, and the research implication, there should be a high quality randomized clinical trials regarding this combination. And I would like to end my presentation not with a code, but an infographic that stuck with me over the years. It's about critical thinking and never stop asking questions. Thank you for your patience.
Thank you for your nice presentation. My question is connected to your vision. So what do you think, how can dentists be the part of the interdisciplinary team what you have visualized?
I would like to see that every ward round has a pharmacist as a core element or core personnel that can provide insights for pharmacokinetics, pharmacodynamics, medication-related problems, adverse events, and how to manage them.
Thank you very much.
Thank you.
A fantastic presentation, I think. I have a question about your third project, which obviously has a fantastic progress. As you can see, all of you, some of the students can present even forest plots after 3 months. But I'm really curious about this somatostatin treatment. So you stated in the introduction that there is no medication actually for treating acute pancreatitis. However, in your PICO, you are only comparing the combined somatostatin ulinastatin treatment with somatostatin. But are there any other trials comparing this combined treatment to other approaches or other medications, or this is the only way?
We find only this somatostatin or octreotide comparison for this combination.
Congratulations on your talk, István. So question number 1 really is related to Silard's question, is there any study that compares what we think is the standard of care for pancreatitis, which is supportive care, against somatostatin, and then studies that compare standard of care against somatostatin plus ulinastatin?
I couldn't find the ulinastatin combination with somatostatin analog compared to conventional therapy. There weren't enough articles.
Because I think if you want to convince this side of the planet, so not Asia, then you have to come up with a proof that somatostatin is beneficial at all. So that's one thing. Question number 2, were these studies blinded? Because they all had slightly soft outcomes, like length of hospital stay, like pain.
Yes, it was randomized.
Randomized,
blindly.
Blinded, double blind. Okay.
Yes, and regarding your first question, I would like to see the results of this meta-analysis or this investigation, and if it has got significant improvement regarding the somatostatin, then I would like to plan an investigation, clinical trial to prove this concept. I asked around wholesalers about procurement of ulinastatin yesterday, but firstly I would like to see the results. Is it possible or is it not?
And coming back to your point of proving that clinical pharmacists are important, so bedside consultation between pharmacists, nurses, and all the other staff of the interdisciplinary team are important. Are you looking into safety? Because I think that is the most important point where you can make the whole concept relevant. That you say, if I am on the ward, I can prevent your patient from getting serious adverse events from single drugs or combinations of drugs which clinicians often are not aware of. So that would be just a comment or suggestion that in the initial phase I would focus on mainly safety issues and patient safety rather than financial aspects, because if you can prove that, I can prevent an ITU admission, an unnecessary ITU admission or unnecessary harm to the patient, that is the strongest point to convince the policymakers that pharmacists are needed.
Thank you for your comment.
On your first study, fine, but what is the control? Because you said that this is beneficial, and then you just look data which are coming actually from the pharmacists. So this is one question, then I have another one.
Yes, I couldn't have a control, it was just a descriptive study, and based on these results and learned from the mistakes, I would like to design this registry initiation project.
Okay, the second question is about this somatostatin. You see, many of us, know a little bit about somatostatin. Actually, I used to do some research on acute pancreatitis, but that was ages, 4 years ago, so very long ago. So when you talk about somatostatin, you talked about somatostatin analog, and then you talked about octreotide. Now, octreotide is a somatostatin analog, but there are other ones too. So when you talk about this, that you use this as synonyms, or you use other somatostatin analogs?
I found only somatostatin and octreotide in the comparison group. Yeah.
Well, the third question is actually coming from Dr. Royce, but he was afraid of asking this. No, not really. That we saw in your forest plots that no, he is not afraid. He's just, told it to me that in your forest plots actually there is quite a bit of heterogeneity among the data. So is there any good explanation on this?
It's a small number of articles. I couldn't find any more. I tried to access Chinese databases, however, I couldn't have access to it. There is more on that, but in English I couldn't find any more articles.